Guys, my name's Lucy. I'm currently in F1, working at York. I'm on my general surgery placement at the moment, and I did 4 months of A&E before that. Really loving it, so that's good. Today I'm just going to talk a bit about IMT portfolio and things that I've done and like you can do to start preparing for when you want to apply for that in the future. So what is IMT? So IMT is internal medicine training. It's a program that is between 2 and 3 years, which is completed in order to go into many medical specialties. What it aims to do is to prepare trainees for participating in acute medical takes at both a senior level and then a junior level when you're from IMT 1 to 3. And this can be for managing acute presentations and also chronic presentations in an inpatient setting. So the 3-year course, so the Group A specialties, where you dual CCT, are things like acute internal medicine, cardiology, endocrinology and diabetes, gastroenterology, geriatrics, neurology, palliative care medicine, renal medicine, respiratory and rheumatology. Personally, for me, I'm quite interested in geriatrics and rheumatology. So a lot of my portfolio is going to be gearing up towards applying to those things. The thing with Group 1 specialties is it's a 3-year IMT, and you then reapply to specific reg posts after ST3. You have to dual CCT when you do a Group 1 specialty. This means that with your chosen specialty, so for me, hopefully geriatrics or rheumatology, you also do internal medicine, and that's integrated into your specialty training. I've put on a little diagram of the process. So you start off by doing your foundation years, so years 1 and 2. So I'm currently in F1. Then after F2, you can apply to IMT. Hopefully you get in and then you do the 3 years and then you reapply again for specialty training, which can last anything from 4 years, depending on if you want to go less than full time. Let's move on. So there's also a 2-year IMT program. So these for your Group 2 specialties. Here you don't have to do internal medicine alongside it. So it's just a single CCT in your specific specialty. So you're not the dreaded med-reg on call. Some of these specialties include things like allergy, dermatology, hematology, immunology, clinical oncology, and medical oncology. I won't read them all because there's lots. So for this, you can single CCC, so you don't do the internal medicine part as well. And you can also single CCT in intensive care medicine with doing the 2-year IMT pathway. I also had a little read into it, and if you did do the IMT 3, you can then also apply to these specialties as well. So the portfolio, so how do you get into IMT? So you have to do a self-scoring system on their portfolio. So there's 6 parts of the portfolio which you can self-assess yourself on. The interviews are then offered on the number of points that you get in relation to this portfolio. So I'm just going to go through the different aspects of the portfolio and then different things that I've done to help me along the way. So the first section is postgraduate. So this would be any degrees or things that you have after you've completed your medical school degree. So there are 4 points available for this section. So the first one, so 4 points is for a PhD or an MD. So this is research of at least 2 or 3 years duration. And yeah, I don't have a PhD. You can get 3 points for a master's level degree. This can be done part-time or full-time. It doesn't count if it's so for example, Oxford and Cambridge, you get your bachelor's upgraded to a master's. That doesn't count for getting you 3 points. It has to be a standalone course that you've done to earn the master's itself. And then you can get 1 point for other relevant postgraduate diplomas, which take between 1 and 10 months. So that is something that I'm going to look into maybe next year to try and maximize my points. I think at the moment a master's is a bit out of my reach. But yeah, just important to note that things like MRCP don't count towards this. Second is presentation. So I think this is something as a medical student, then F1 and F2, that is easier to score some points on and to work on your portfolio. So there's 6 points available for this. You get 6 points if you've done an oral presentation in which you were first or second author at national, international meeting. So that means for example, the British Society of Rheumatology, their national meeting, their national conference is the BSR conference. So if you presented an oral presentation at that, that would be 6 points. You do have to be able to prove that you've done that. So this could be an abstract that was produced as part of that. You get 4 points for a poster at a national international conference. You get 3 points if you've done an oral presentation at a regional meeting. And then you get 2 points if you've done an oral presentation, which you're first or second at a local meeting. So for that could be things like in the hospital, if it's a clinical meeting, if you presented your work at that, I think that would count for 2 points. So like I was saying, I think this is a really good part of the portfolio that you can work on early. So I did a project in 5th year with the rheumatology department at Salford, looking at steroid prescribing and adrenal insufficiency, and then looking at whether the patient education around that was sufficient. So from that work that I did as part of the degree, I had to do the work for the degree. I've been able to spin that and get some stuff. So I've done an oral presentation of it at the Northwest Rheumatology Conference. And then in April this year, I got my poster accepted at a national conference. So just any work that you're doing, just think, can I present this? Talk to your supervisors, and a lot of the time they'll be very keen to help you. So just be proactive asking those questions. The one thing I will say is the national conferences are really expensive. So the BSR conference is about £300. So just keep that in mind. And I'm sure there are ways of getting it funded, but just being aware of that early as well. So the third section is publications. So this is the one with the most amount of points available, and that's 8. And personally, it's one I'm struggling with the most to fill. Advice-wise for publications is just speak to supervisors early if you really want to get involved and get stuff published. So you get 8 points, the maximum points, if you're first author on a PubMed cited original research publication. And then you get 6 points if you're a co-author on a similar paper. You get 5 points if you are first author in one or more of other publications, and this can be things like editorials, reviews, case reports, and letters to the editor. I think these are things that as a medical student and F1 that are easier to achieve. So just asking if there's any interesting cases that your consultants have seen that they think would be a good case report and trying to get those published. 5 is you also get 5 if you've written one or more chapters of book. They can't be self-published books. I don't have anything to say about that. Haven't written anything for a book. You get 3 points if you're first author in just one of an editorial case report or reviews, and then you get 1 point if you've published one or more abstracts. So I've got 1 point at the moment because the poster that I'm doing for BSR, they publish the abstracts in their newsletter. So that's a good one as well to get a point. So just being aware that some posters will what's the word? Will also publish the abstracts that you've done. The fourth section is teaching experience. So this is one that I've tried to really maximize this year. So there's a total of 5 points available for this section. So you can get the maximum points, which is 5, if you've worked with local tutors to organise a teaching programme. So that must be a series of sessions that are delivered to either healthcare professionals or medical students. You must have taught regularly over a period of 3 months or longer in the programme you've organised, and you must have evidence of formal feedback. So this can be feedback forms, it could be specific forms in your portfolio, or certificates that you've had from the teaching that you've done. You can get 3 points if you provided regular teaching for either medical students or healthcare professionals as part of a defined programme or course. You've just not necessarily organised it for the 3 points. So this again has to be over the 3 or more months, and you have to have evidence of formal feedback. So examples of this could be regular bedside teaching. So I don't know if everywhere has it, but we had it at Manchester and they have it at York with a foot scheme where you're paired up with 5th year medical students and each week you provide them with a bit of bedside teaching. If you do that for a period of 3 months and you make sure that you've got evidence of it, that would be 3 points. And then you can get 1 point if you've taught medical students or healthcare professionals occasionally. So this could be that you've done the odd bit of teaching, you've got a feedback form from them. Just making sure that anything that you do teaching wise, that you have proof that you've done it. So this could be certificates, a feedback form. Once you get to F1, you have DCT forms, which is developing the clinical teacher. So you're getting those to support as well. So for me personally, what I've tried to do is I organise a teaching series which focus on the aspects of medical school which I felt we didn't particularly cover in much detail. I made sure that it ran over 3 months, and I taught 4 of the sessions. So it's just every week on a Wednesday, 7 till 8, we go over a topic. So our last one is this week, and it's ophthalmology. The way that I've got proof of that is I have feedback forms from the students who attended, and then have popped that into my portfolio to make sure that there's ongoing proof. I've also taught at a foot scheme, which is run at York. So I've been paired with fifth year medical students, and then throughout the year, I've been doing bedside teaching weekly with the students. I've also taught some one-off sessions for the medical school at York, so the whole York Medical School, and then I've just made sure that I've got DCT forms for each of those that I've done. And I am Mind the Bleep Rheumatology Finals Lead, so I do monthly teaching for the different aspects of rheumatology, which has been over a period of 3 months, and I'm involved in the organisation of that as well. So that you don't have to do all of that. It's just some things that I've done because I'm particularly interested in teaching and found that it's been the easiest part of my portfolio to maximise my points. And then the fifth section is about formal training and teaching. So there's only 3 points available for this section. So you get 3 points if you've done a PG cert or a PG diploma. So it needs to be university accredited and the equivalent to 60 credits. If you do SFP, some of them come with PG certs and PG diplomas. So if that is something you're interested in and you've not applied yet, or you're in 4th year, thinking about whether that's something that you'd want to do. So apply for these SFPs with who fund the PG cert and the PG diploma for you. You can get 1 point if you've had formal training in teaching, and this just has to be formal teaching have lasted at least 6 hours, so a 1-day course. So I haven't done anything like this yet, but it's definitely something that I'm going to try and get done after I finish my general surgery placement, because it's just a bit busy at the moment. But I think that's a good, just doing a 1-day course to show that you are interested in training is a good way to maximize your points as well. Finally is the quality improvement section. So this is a total of 4 points available. So you get the maximum points if you've been involved in 2 cycles of a QI project. So this means that you've participated in all of the sections of the PDSA cycle. So you've planned, do, study and acted, and you've been involved in 2 cycles. And you must have proof that you've done that. So this could be certificates from the hospital, evidence of the work that you've done itself, so the actual audit and then the presentation of the audit. You can get 3 points if you've been involved in some of the stages of the 2 cycles. So for example, if you were just doing the data collection as part of someone else's QI project, but you did it for the 2 cycles, you could claim that there. And then you can get 1 point if you've been involved in some of the stages of a single cycle of a QI project. So example, it could just be that you've done the data collection for the first part of someone's QI project. So quality improvement, again, is another one of the sections that is easiest to get involved in. There's lots of opportunities in hospital. You just need to make your supervisors or people that you work with aware that that's something you're interested in. So things that I've done to help me during F1. So I didn't start any of this as a medical student, but I've got involved in a couple of QI projects as an F1. So firstly, I just created a survival guide for new F1 doctors for A&E. So this would just be me being involved in part of one cycle. So that was good, and it was easy to do while I was getting used to F1. So I've got a certificate to prove I've done that. I've also been involved in data collection for fragility audits. I'm also interested in geriatrics. So again, that's just one part of the PDSA cycle. So it would get me the 1 point. And I've recently started a QI project for syncope in older adults who present A&E. So I'm currently doing the pre-audit phase for the first cycle. I'm trying to take a joint leader role in this QI project. And the aim for this QI project is to be involved in all of the cycles, so hopefully I can get the maximum points. Again, when you're choosing your QI projects, just make sure it's something you're interested in, because it can be a little bit of work outside of it. But most people will be really happy for you to get involved. You just need to show initiative and like ask for opportunities, or if there's something that you've noticed on the ward that you think needs improving, you could make your own QI project. Just make sure you know who to contact like in the department about it. That was very quick. I felt like I spoke very quickly. So apologies for that. If anyone's got any questions, you can pop them in the chat. But if not, I think that's my bit done.
I think there's a question in the chat about the public, I think for the publications, what the difference is between 0.3 and 5.
Hang on 1 second. So the 3 would be that you've just done one of them. So you've either done one case report, one review, or one editorial. If you've got more than one published, so example, you've done 2 case reports or you've done an editorial and a case report, you could then say you've got 5 points. So it's just about the number that you've done. How many points? I think the cutoff this year was, I want to say 15 or 16 through word of mouth. I'm not completely sure on that one. Apologies. No, they're not cumulative. It'd just be that you can only get 8 points for the whole of the publication. It'd be your highest. The thing in the highest bracket would be the number of points you got.
I had a question. With all like the teaching and all the research you've been involved in, how have you found like time to balance like work in terms of work-life balance?
Yeah, that's a good question. It's been a bit tricky. I'm really bad at just like sitting down at home. But it's just like on a day off, I might spend an hour doing a bit of work. And with my teaching series, I taught 4 of them, but I outsourced and got other F1s involved. So that really helped with like work-life balance. But I think you do just have to accept that you might have to do a little bit of work outside of work. But I really enjoy teaching, so I don't really, so far it's been okay, if that makes sense. And I do a lot of running, which I think helps keep me very balanced.
Thank you. Are there any more questions? Do not think so. We do have a bit more.
I don't think you need to go through any official channels. I really hope not, now that I've done it. I think you just need to be able to evidence that you've done it. You
Just to
can't.
quickly answer this, sorry
Okay.
to jump in.
No, go for it.
I'm an F2 and a lot of my friends are applying for training at the moment. The DCT that Lucy mentioned is a part of your F1 and F2 formal curriculum. So it is recognised because it's signed off by a consultant. When I did a 12-part series as well last year, guys, I would always recommend with everything like this, team up with your friends. You can do something much bigger and more impactful working together than you have to do all by yourself. What you need is letter-headed paper from your trust and a consultant to basically write a little thing that says this is to like certify that I have seen the feedback, recognized that Lucy Miller completed a 12-month teaching series. Most consultants, like your educational supervisor or your clinical supervisor, will be so happy to basically write what you want them to certify if you send them the evidence and make them aware before you do the series. And it's in their interest to get you this evidence. It's literally what they're paid for. So if you're in F1 and F2, your educational supervisor. If you're in med school, ask your tutor or your educational supervisor. But yeah, hope that helps.
Well, that was really helpful. Thank you. I need to get in contact with my educational supervisor. Fab. Yeah, I think if you do like an F3, you can do things like PG Cert. I'm not actually 100% sure. I think Meg would probably be better for answering those sort of questions.
Yeah,
okay?
sorry to quickly say, you can do a PG cert for a teaching fellow job, or if you're in medical school, you can get a priority program with a PG cert included if you can't get on an SFP. So you can choose to work somewhere like less desirable in the country where they don't have as many applicants, and as an incentive, they'll fund you to do a PG cert. So if you're really passionate about it and you don't have like a massive priority to a certain place, your options are priority program, a teaching fellow job, or you can like locum in F3 and self-fund it if you want to. Yeah, those are like some of the options. Tony, shall we maybe move on to the next speaker?
Yes. So Dr. Bhatti, are you ready?
Ready as I'll ever be. Right, good evening. My name's Dr. Bhatti. I am a respiratory registrar working in Rotherham at the moment. And this evening I'll be talking a bit about kind of a career in medicine, so to speak. Just medicine, not as bad as everyone tells you it is. I'm aware that medicine and IMT gets a bad press. And to be honest, even from medics, IMT gets a bad press. But it really isn't as bad as people think it is. So I'm going to go through a couple of different points. So I know there were some things that were kind of mentioned on the medal page. I was sent a kind of list of bullet points, so I'll just kind of hope to address a couple of those. So where does internal medicine sit? So as Lucy went through in her talk, this is kind of how the setup of training goes through. So generally people are around here or possibly here at the moment. With any specialty that you do occasionally you'll have things that have run-through training like obs and gynae or pediatrics. You'll have GP training, which is just 3 years, and then you go into being a GP. But with other things such as surgery and medicine and psychiatry, you will do either a number of years of core training, usually 3, sometimes 2. If you do ACCS, either for emergency medicine, acute medicine, or anesthetics, that might be 4 years. And then you do your specialty training years. Okay. Once you finish your specialty training, however long that takes, people go less than full time. People take time out to do out of program experiences or fellowships. You then go on to the lofty heights of being a consultant. And what is it that you can actually practice in? So medicine, oh, flipping hell, how do I get rid of the annotations? God, I feel like such an old man. Never mind. So in terms of the specialties, medicine covers a wide range of things. And these are all the things which, again, Lucy had kind of shown on her slides. So the ones which are highlighted in blue are what we call groups on one specialties, where you do that specialty and you also dual accredit in general internal medicine, i.e. you have to be the med-reg. The non-highlighted specialties are group 2, where you end up having to do your own on-call or things which aren't necessarily on the on-call rota. So, for example, clinical oncology, medical oncology, microbiology, hematology, they don't have to take the role of the med-reg, but they will have their own on-calls. So it's not that you get out of them completely. Rehab med, I didn't realise they'd got out of med-regging, but a couple of other specialties where you wouldn't have been the med-reg before, such as palliative, neurology, and rheumatology, have now been brought in under that umbrella, with the idea that there are more generalists on the acute take. So a week in the life of a medic. It varies a lot from grade to grade. So when it comes to doing IMT, I'm going to open from the start. It is not a great training program. I'm not going to sit here and try to sell IMT as this fantastic, wonderful training program, which I appreciate is a bit bleak, but it's the truth, really. When I was a IMT, so I was in kind of the first year that did it. The reason IMT was kind of introduced compared to core medical training is that instead of just doing 2 years of SHO and then going straight into being a med-reg unsupported, the idea was that by having the IMT 3 year, it was kind of a semi-supported reg role. But again, that varied a lot from place to place, because sometimes you would just have 2 IMT 3s on when you're on call, which doesn't necessarily add that kind of supported introduction to being a reg. A lot of what I did as an IMT1 and IMT2 was very similar to what I did as an F1 and an F2, in that it was doing the ward rounds on the ward, doing the jobs in the afternoon, trying to squeak off to clinic at some point. And again, it varies a lot from hospital to hospital. Some of them are quite good at trying to give you kind of self-directed time, so you're able to try and attend clinics and get your procedures signed off place to place as to how much you get out of it. I know certainly during my first year of IMT, I felt like in some ways I was probably regressing, as I did fewer ward rounds by myself as an IMT than I did as an F1. And I think that probably says more about my time as an F1 than it does about IMT. But with a lot of places becoming a lot more senior led, it can be really frustrating where you're 4 years in and basically doing the same job. With more people taking time out at kind of F3 and F4, which is essentially a rite of passage at this point, you end up spending more and more time as an SHO. So it can be a bit depressing, really. It does get better as a reg, not only in terms of the on-calls, and yes, you have to be the med reg, but I'll come on to that in a second, in terms of the variety of the work. So I am a respiratory reg. I've been at Pinderfield for last year, which is where I met Rachel, who kindly invited me to talk this evening. And my week would be a variety of seeing the medical referrals, sometimes being in clinic, doing the procedural work, so kind of chest drains, pleural aspirations, opportunities to go to bronchoscopy, EBUS, thoracoscopy, as well as ward rounds as well. So, and occasionally there is also time to kind of catch up on the admin and do the letters and things like that. So it is a much wider variety of things. The other thing is, because you're there for a longer period of time and you're essentially training to be a consultant colleague, there ends up being a different relationship between you and the consultants, and it ends up being probably a bit of a nicer one, compared to when you're an F1 or an SHO, where it feels like in some areas they just don't really care or don't seem to pay attention. And yeah, it will vary a lot from specialty to specialty. It varies a lot from hospital to hospital as to what your average week will look like. There are some specialties where you'll have a lot more procedural work. There are some specialties where you have a lot more in the way of clinics, but that depends entirely on what it is that you go into. So in terms of the path that I took and how I ended up in respiratory, so going into med school, I think probably from watching one too many episodes of Frasier as the really cool sixth former that I was, I initially thought about, potentially pursuing psychiatry as a career. It was something that not many people did, undersubscribed, helping people in that sort of area. And then I remember starting medical school and sitting through the lectures for histopathology and anatomy and physiology and thinking, God, if this is medicine, then I don't know what the hell I'm doing here. I'm just going to pick something. I'm just going to be a surgeon. I'll learn anatomy, become a urologist, carve out some prostates on the weekend, go live my best life. So for a couple of years, I started kind of pursuing surgery. So my SSC, so in our fourth year, we have student selected components. I don't know if they're still a thing at Newcastle. I really hope they are. But as part of the student selected components, I did 2 blocks which were surgically inclined. I started getting involved in kind of QIPs and projects with kind of a surgical background. Started going to the student conferences, that sort of thing, to try and get involved from a surgical point of view. And then I went on my elective at the end of fourth year. So I was in Vancouver, where I did 4 weeks of general medicine, which was fine. And then 4 weeks of ITU. And it was on the ITU there where you saw like a really wide range of cases and people who had kind of, medical pathologies that kind of made me think, wow, maybe medicine isn't too bad. And, with ITU, you get to do lots of procedural work. It's not too dissimilar to surgery. You get a bit of acuity. This is quite fun. So then I kind of changed tact away from surgery more towards kind of an ITU acutist point of view. And going into foundation, I thought that would be the path that I would go down, with a plan to kind of go into ITU and probably anaesthetics, because that's the classic one that goes with ITU. And I remember getting my jobs for foundation. So anyone up in the Northeast, I was in North Tees for 2 years. And my jobs for foundation, I got general surgery for 4 months, 4 months of stroke, 4 months of ortho-gerries. And I got that 8 months of stroke and ortho-gerries, and I thought, oh my God, this is going to be grim. Sorry, Lucy, but there we are. And actually, the on-calls that we did as an F1, we ended up clerking on the acute take. And I worked with a lot of fantastic consultants who would actually teach, were very knowledgeable, and you kind of trusted what they were saying, which made me think, well, actually, maybe medicine isn't that bad. And I didn't like my stroke job at the time, but actually learned a lot from it. And I really enjoyed my orthogeriatrics job because we had two nurse practitioners on there where they would sort out kind of the bloods, the cannulas, the discharge letters, the ABG. So I didn't have to worry about any of that. I would go, I would do medicine, I would do the ward round. And they were generally a very, very nice team. So I really enjoyed my time on there. And actually, as I spent more time on the acute medical take and spent more time doing what is essentially pragmatic medicine, I started moving away from the idea of doing ITU and anesthetics. But, start of F2, I decided, you know what, I'll do a taste a week, see how things are, see what I think of it. And I was just really bored. Like, I know people like anesthetics and people talk about ITU and anesthetics, and I think in some respects they do provide much better training and better training and better oh God, what's the word I'm looking for? Mentorship, so to speak. But I just didn't like it. It didn't suit me. And there's always lots of anaesthetists who say, "Oh, we have the best specialty. You should become an anaesthetist. We drink coffee all the time, whatever." But I was just really bored sat in theatre and going around on ITU. You'd have lots of people on ventilators. They were tubes, and you'd just essentially be fiddling with numbers. And I kind of thought to myself, well, if I wanted to make numbers look better all day, I would have gone into accounting. The thing that I liked about medicine and the thing that I realised that I liked wasn't necessarily the acuity, but actually being able to be pragmatic, make good decisions with the focus of looking at the patient's quality of life and doing what's best for them. And having spent time on the acute take and actually really enjoying it with some of the fantastic consultants at North Tees, I actually thought, well, actually, I think I probably want to be an acute medic. So at that point, I still enjoyed medicine, so I went straight into IMT. So I'm from Doncaster. I don't know if anyone knows Yorkshire, but my accent isn't really from Doncaster. But I decided to go straight into training and move close to home, so moved to West Yorkshire. And started IMT, and for kind of some of the reasons that I said before, it was just a bit bleak because I hadn't really moved on from where I was as a foundation doctor. And it seemed like no one really cared much about training. And then COVID came along, which wasn't ideal either. But as I went through, I still think, well, maybe I probably will go into acute med, but we'll see how things go. And then I did my acute med block as an IMT3 in Leeds. And I just decided I absolutely do not want to do this. Partly because the way that the take works at Leeds is it's essentially dumping ground medicine. So you don't see lots of different specialties. It's just kind of the leftovers of what no one else wants. But also how the team prioritized and again just didn't really care about me as an IMT3. And while you shouldn't base your job aspirations on what one department is like, and I'll come on to this a bit into the challenges of the specialty, but there was a very clear shift towards non-doctor led care there. And I thought, well, actually, from an entirely self-preservatory point of view, if the NHS is going to crap, I kind of want something where I am going to be able to not have to work in the NHS, and B, have something where I have my own subset of skills. And that's not to say that acute medics aren't skilled. They are certainly skilled in their own right. It's a specialty that everyone thinks that they can do well, but in reality, only certain people can do it well. But I figured I would do something where I'm able to kind of still have an area of specialty and still work in a specialty that exists outside of the UK should it all collapse. So I'd always had a soft spot for renal and respiratory. So I locumed as a registrar for 18 months with the initial plan that I'll do maybe 6 months of respiratory, 6 months of renal, decide from there. I managed to get a job doing respiratory as a locum for 6 months. There weren't any renal jobs afterwards, and the respiratory department I was working in said, "Do you want to stay?" I said, "Are you going to pay me locum rates?" They said yes, so I stayed. So worked for a year as a respiratory reg, and thought, well, actually, I don't mind this. It's a good balance of, pragmatism. There's acute stuff, there's chronic stuff, there's lots of practical stuff with the various procedures that I talked about. And it is still pretty general medicine. So a third of the acute take that comes in ends up being respiratory of one form or another. So that's how I ended up in respiratory. It certainly wasn't a case that I woke up one morning and thought, you know what, I bloody love alveoli. And I think it is rarely the case that people will wake up and decide that they really heart hepatocytes or, love an organ. Occasionally people do. But what I would say is that the reason you fall into a specialty and the reason people go for a specialty isn't necessarily because of the organ or the system itself, but because of the work and because of the team. And like I said, I'll talk a bit about that at the end in terms of my tips. Rachel or Megan, Frank, if I am wittering on, please stop me. But I will carry on until then.
No worries.
Challenges of the chosen career. I think challenges of medicine is that, like I said, IMT is a bit crap. It is the thing that you do to get to the specialty and the job that you want to do rather than something that you do for the sake of the joy of the training. Other challenges which aren't necessarily limited to medical training, but we're seeing throughout specialties, as I'm sure you can see, are limits to bottlenecks of training at various stages and the move away from physician-led care, which, put bluntly, it means that there's more competition for things. With the kind of non-physicians who are being brought in, they do provide kind of continuity, which means that people end up being a bit more invested in training them because they're going to stay there. They can learn the skills and they'll make their life a lot easier. I think we're doing that at the sacrifice of people who are going through, and we're going to end up with worse consultants as a result of it, but that's a rant for another time. One of the things that everyone says is, and just in terms of the chat, everyone is aware of the role of the med reg. Is that fair to say? So, the medical registrar is essentially the default of what do I do in the hospital. So at each grade, you end up having a different title. So as an F1, you are a foundation doctor. F2 is technically F2, but it comes under what was previously known as SHOs, which is stuck, a senior house officer, and the same as when you're in core training, that is a house officer. A senior house officer. Once you've finished being an SHO, you move on to being a registrar, which is essentially the rung below being a consultant. Now, whenever someone becomes unwell in the hospital and the other specialties don't know what to do, usually the person who gets rung is the medical registrar. So if there is a surgical patient who is unwell because they've got a pneumonia or something kind of non-surgical that's going on, they'll ring the med reg. If there is someone who's come into maternity and they have an arrhythmia or they've come in with seizures, they'll call the med reg. If you have someone who's unwell on a medical ward, they'll call the med reg. Anyone unwell in A&E with a medical problem, you can see where this is going. A lot of people will say that it's probably one of the worst jobs in the hospital. It is busy, it is challenging, and people who've worked with med regis, you'll kind of see them. They'll turn up, they'll say something, and everyone thinks, oh my God, how do you know all of this? I can't possibly know all this. I certainly felt that when I was an F1 and an F2, where the med reg would kind of like come to the rescue and kind of consider them a minor deity in what they do and what they know. Rachel, I hope that you felt the same way when I was there as your registrar in Pinderfields. I'll be disappointed if not. But there is always that fear of how the hell do I become the med reg? And it can be challenging, it can be tricky, it can be busy, but it's actually a really good job because it ends up being the thing that you went to medical school for, which is seeing unwell patients and trying to make them better. And yes, you do have to make big decisions, and yes, you will be asked lots of questions. But actually, after that, at the point where you end up becoming the registrar, you are 3 or 4 years into it, you are fed up of being an SHO, and actually having that bit of responsibility can be quite nice. But it's also the fact that, without sounding like power's going to my head, you get respected a lot more than you do at any other role, because there are very few roles in the hospital where you can walk into a room and say, hi, I am X, and everyone will turn around and say, okay, fine, what do you want us to do? Like, help us. Which is quite nice. And then the conversations that you were having previously, which ended up being a lot more kind of argumentative or trying to get your points across or someone not listening to you, end up being more of a dialogue. So it can be challenging being the medical registrar if you end up picking a role where you end up being the medical registrar. But I would say that of all the things to do in IMT to put you off being a medic, being the med reg should not be one of them. And I think I've talked a little bit about this. So how does the career change as you progress through training? When you're at the point of looking at careers, don't look at the job that the SHO or the registrar is doing. Because the job that you do as an SHO is different to the job that you do as a registrar, is different to the job that you do as a consultant. And sometimes when you are, and as you get further along, you kind of see more and more what being the consultant involves. Because sometimes when you're at F1 or F2, you kind of see the consultant turn up for a ward round and then just kind of disappear. And you kind of think, oh, what are they doing in the office? They're doing a lot. Usually it's catching up on a big pile of letters, or all the blood results that get requested under someone's name. It ends up being the consultant's name, so they need to look through all those blood results and make sure they're actioned. They're dealing with complaints, they're doing kind of QIPs and their own projects in the background, they're dealing with managerial things, and they end up having all these different things which are in there. So certainly the career does change as you progress through training, as you take on different roles and you take on different responsibilities. And it's the same with every specialty. So, for example, in ED training, or when you're an ED trainee, you spend a lot of time on the shop floor. When you're a consultant, you'll spend far less time on the shop floor seeing the unwell patients because you end up taking a more supervisory overview. And actually, you will spend a lot of your time doing paperwork. So don't necessarily look at the job that it is when you are at one of those lower stages. Have a look at what the job is going to be at the end of it when you're thinking about the specialty that you want to go into. So the next two questions is kind of like what makes certain people stand out. Different people have different answers to this. I think, in my opinion, the thing that will make someone stand out is a good attitude. I don't care if you don't know the answer. If you don't try to know the answer, or you kind of repeat it, or you kind of learn the answer once and then forget it, and you don't think about trying to learn it or read about it, then I'm going to think less of you compared to someone who like actually goes in, thinks about it, looks, at least reasonably keen, and actually I know is going to be able to do that job. Knowledge can be taught easier than it can to teach attitude, and actually going in with a positive attitude, trying to get involved on the ward, asking what can be done. Sometimes the answer is no, and sometimes you will actually have teaching sessions to attend, but trying to get as involved as you are allowed to, I think, is a positive thing, and it shows because when you go, and it pays dividends, because when you go forward, if you go in with that kind of positive attitude where you are willing to get involved in things and make sure you get things done, it will reflect positively on you. So then when those projects and those QIPs do come up, people are more likely to go, I know they'll get something done. They will probably be a good person to try and bring on board. So it opens up more opportunities for you. The other thing is, if you set a good example as to who you are as a person and the sort of attitude, if something does go wrong, people give you an easier time of it. If you give off the impression that you're lazy to begin with, if something goes wrong, they will probably just kind of add it into the cons list. One of the things I'll also say is that sometimes it can feel, especially as an F1 or an F2, that the consultants and the regis aren't paying attention. They are. It might not seem like they're paying attention, but they are paying attention to what it is that you're doing, what it is that you're not doing, the jobs that are or aren't done. And while they might not, you might hear something back at the end of the placement. There are WhatsApp groups for the consultants, and they will probably be having a bit of a chat between themselves as well. Not to like scare the crap out of you all, but don't think just because they're not saying things that they're not paying attention to things. Again, I think show keenness. One of the tips that I would give in terms of the opportunities as a medical student or a resident doctor is making sure that you don't fall into like a sunk cost fallacy, where you get involved in something and they'll say, oh yeah, this will be really great. where they just kind of use you to do the audit work and not give you anything as a result from it. I think with some of the things, and in terms of especially now things getting a lot more competitive, with the portfolio, it is points mean prizes. And the medical students have a much easier time of this because if you have a local conference, say at Newcastle have a surgical conference and they have the Academic Medicine Society conference, or at least they did back in the day, because they put those out as offered those nationally, that's actually how I got an oral presentation because they advertised it to a load of medical schools. So technically it counted as a national conference. It was about kidney stones, I think mine was. But it counted as an oral presentation on a national setting, which means I got maximum points. But when you are on a placement, if it's something that you're interested in or you're looking for an opportunity, speak to one of the registrars, speak to one of the consultants, you'll get a vibe. And, when you speak to the F1s and the F2s, who are probably who you'll spend most of your time with, they will probably point you in the right direction as to, oh, that reg is really nice, or that consultant's a bit of a dick, don't speak to them. And they will kind of guide you towards probably who would be good people to speak to and where to find these opportunities. And again, be clear as to what you want to try and get out of it. Don't go in saying, I want this, 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 and this, but kind of say, well, I'm trying to look for this for my application. So if we could do this, this would be great. And, if you're not getting anywhere, then don't be afraid to cut at the first available opportunity, where if you think they're just going to be using me for crap, you can do a bit of the data collection or whatever, and then just cut your losses. Don't stick with a bad project just because you're being made false promises, if that makes sense. I'll answer questions at the end because I can see one or two in the chat. See previous comments, projects and publications. Again, so intercalated degrees aren't counted anymore in terms of points for applications. It can occasionally be a way to get publications, but it's a very expensive way of getting publications, so I wouldn't be in a rush to do that. In terms of projects, again, if you have student selected components, that can sometimes be a good opportunity while you're on the ward. If you speak to the supervisor early on and say, hi, I'm interested in doing a project, have you got anything going? They might be able to provide something for you. And yeah, publications, it can vary. So I've not got a PubMed publication. I wrote a chapter for a book when I was an IMT 3, and that's because someone kind of dropped me a message and say, this opportunity is going, are you interested? It can sometimes be quite tricky. Some people will be more academically minded than others. It can sometimes be very difficult as a medical student to try and pick a publication. But projects are potentially doable in 8 weeks. It might take a little bit longer to do that, but it depends on the project. Again, it doesn't necessarily need to be a good project. It helps if you can talk about it and it's not just the same standard oxygen prescribing VTE assessments. But as long as it is something that is 2 cycles, that's what gets you the points. Yeah, general top tips. I talked about some of the things there. Show a good attitude, show willing, and people will be more willing to give you opportunities and kind of take you under their wing and try to teach a bit more. Yeah, in terms of the application, it's points mean prizes. Read what each thing involves and have a look at the effort to point ratio. So doing a PhD for the sake of 4 points, that is very poor because you're essentially a year per point. Doing 2 cycles of a QIP is a far more effective way of your time, far more effective use of your time in order to get those points, in order to get the applications for IMT. What was the top tip? I had some. No, I can't remember. Oh yeah, as a foundation doctor, it's not necessarily your knowledge which is the thing which is going to make you stand out. Again, it's the effort and willing and making sure that you can kind of get the jobs done, even from day one, even if you don't know what you're doing. If you show that you're willing to learn and that you can handle a jobs list, even by the end of the 4 months. If I know that actually I can give you some jobs, those jobs are going to get done, that's going to stand out far more compared to someone who can reel off some, really big answers, but is particularly lazy or work shy. And that's about all I can think of. Thank you very much for listening to me prattle on for longer than I probably should have. Are there any questions? I can address some of the ones in the chat if you want.
And I have a question.
Yes.
What would you say has been the highlight of your career?
The highlight of my career?
That's not a heavy loaded question.
It depends what you class as a highlight, to be honest. There are stories from my career, which are entertaining in their own right, which kind of stand out for me. There are patients who stand out partly because they are wild or just incredibly nice people. And then there's the occasional kind of wild rogue diagnosis that I've managed to make out of somewhere, which ends up just being quite a fun story to kind of show off. So I think it's difficult to pick a highlight. There are always going to be lots of ups and downs during your career, but you'll be surprised the number of times people kind of go out of their way to say thank you, as in slightly less than you'd think. But when people do that, it ends up being very nice. And from the occasional card that I got, I ended up keeping them somewhere. So there was a patient when I was at locuming in Doncaster, who was an ex-matron who came in a local hospital, who came in with a unilateral pleural effusion and was concerned that she had cancer. Spoiler alert, she did. Now, for the first couple of days that she was on the ward, she hated everyone. And she was making complaints, like the nurses were almost in tears, the consultants were almost in tears. She was like picking up on everything. And then she needed a therapeutic aspiration. So I don't know whether it was just kind of like the general chat or the reassuringness, or she just kind of warmed to the ward. But, after I'd kind of done this with the consultant watching me, she was certainly a lot warmer to staff on the ward, and she was quite nice by the end of it. And she actually got me a present as the reg after looking after her, which was really nice. Now, the problem is I didn't actually get the present because she told her husband that she was going to get me this, and it turns out she was going to get me like an engraved pen. Unfortunately, she died before she had the chance to get it engraved. So her husband brought the pen to the ward and gave it to the ward sister, saying, "This is a gift for the doctor who's looking after me." Didn't mention me by name, so the sister gave it directly to the consultant. Now, I couldn't, as the registrar, go to my consultant and say, "Excuse me, sorry, I believe that gift is for me, not for you." But it was very nice to be recognised in that way. And even if I didn't get the Parker pen, which sort of sat on a shelf in the end, but it was nice to be recognised, not necessarily because I did anything important or heroic, but because they appreciated what I'd done.
Well, thank you for that, Dr. Bhatti.
I'm happy to answer those, and if anyone has any other questions just pop them in the chat. And similarly, I'm happy to give my email address at the end, although lots of people have already left. How important is it to view tertiary versus secondary care for IMT training? So more often than not, you end up doing a mix of kind of general DGH and tertiary care. I don't think it really matters. Arguably, you'll get better training in a DGH because they're less protective compared to the tertiary centre. Some people really prefer tertiary care. Some people really prefer being in a DGH. I'm personally a DGH bird, but you'll end up spending time in both and you'll work out what works out best for you. Do you need to pick an end specialty from end application? So the only time that you need to pick your end specialty is when it kind of comes to higher specialty training. So if you go down the IMT route, you can see that it opens up a lot of different pathways, and you'll find something that fits you in terms of what suits your personality and what you like. So you don't need to pick this until later on. I only settled on respiratory after I'd finished IMT 6 months afterwards, and that's when I applied. Even then, you have people who apply for 2 or 3 different specialties, partly because they're not sure, partly because there's a couple of different things that they'd like. And then the reapplication, again, it's very similar. I wouldn't worry about it just yet, especially as a 4th year student, because you'll forget about it all by then. and the scoring system probably would have changed significantly. However, you generally get scores and points for the similar sort of things. So doing a number of QIPs, doing doing QIPs, doing teaching, getting involved in posters and publications. You get points for MRCP, which you don't at IMT, but I would suggest looking at that closer to the time. In terms of the different posts by structure and deanery, it's difficult. Sometimes deaneries have their own really good websites. Sometimes they end up being a bit crap, but looking in individual deanery websites can be a really useful resource. At SSC, it depends on your SSC and what it is that you're doing. Sometimes it can be enough time to get involved in the project. So the one that I did on the renal stones, I did during one of my SSCs, and I turned that into a poster and a oral presentation, which I presented at my local university, but because it was a national invite, it counts as a national presentation. So got a good chunk of points for that, and I didn't have to cough up 300 quid for a conference. Bottlenecks higher at specialty training similar to those after F2. They didn't used to be, but the bottlenecks are starting to kind of shutter through. So it always used to be a bit more difficult to get a higher specialty training job than it did to get an IMT job, but I think everything is just getting more competitive. Again, the biggest thing is kind of points mean prizes, and speaking to people in that specialty to try and point you in the right direction. Usually, if you kind of go in with that keenness and a good attitude, someone will take you, or someone should take you under their wing and guide you accordingly as to what you need to do. And, if it's a specialty that you enjoy and you're keen on doing, if you say to those consultants, I'm thinking about doing this, usually they will try to help you out to get